A very good afternoon. I'm really thankful to Dr. M.S. Mathur and the university for hosting this first ever conference on early childhood caries. And I'm really thankful to the speakers, those who spoke before me, and giving us the insight on various aspects of early childhood caries. And especially Dr. Swasti Charan, who spoke during the inaugural function, he gave us a lot of insight. The Vice Chancellor was quite thoughtful and has given a lot of ideas to us and inspiration to us to go forward in this direction. The presentation of mine is on the prevention of early childhood caries using existing health infrastructure, the possibilities and proposed model. As the title says, these are all my ideas, my proposals, and I do not have any conflict of interest to present for this. The contents are mainly taken from the government documents, websites, and my personal experience. We all have data on disease prevalence, but on impact on life of children and family, we do not have the much of data. Actually, if we have the data that how many days a child could not go to school, or how many days a child could not eat due to early childhood caries, or how many days the family members or the parents had to take leave from the office to take the child to the hospital, and maybe what is the cost of the treatment. If we have those data, we'll be able to influence more on our policymakers. They do not get much influenced by the data of prevalence what we give to them, because prevalence comes out to be very high to the tune of 50%. And if there is a disease which is 50%, then there should be a havoc in the society. So they feel that it is not a very urgent disease. So there's a gap between what we think and what policymakers think. If the policymakers come to know that how much of money spent will save how much for them in the terms of disability adjusted life years, or in terms of economic advantage due to prevention, then they'll be able to pump the money. This is the other aspect which we as dental professionals do not think of. Past 21 years, I have been in touch with the government bodies due to my various positions from very junior to now a professor. So I can tell you very, very frankly that even in the health sector, the government thinks of the actual profit out of spending money. And if we do not have adequate data, we will not be able to influence them. We know that early childhood caries is a significant public health problem. Uh, and it has been emphasized again and again since morning. But I want to mention two more important aspects. One is that the sufferer of this disease is actually not a able human being. This child is a dependent. And if we are not able to prevent the disease in a dependent human being, then we are causing inequality in the society. Inequality not in terms of families, but within the family. So this is a major issue. Then, if we are not able to treat the children for early childhood caries, and if they suffer, then it should be taken up with the governments as a matter of social injustice to those children, those who are affected. And that number is not small, my dear. That's a very, very large number. And we all should be taking serious thought about it, that our thought process has actually not resulted in much of the benefit to the children. And I hope that conference like this, the deliberations like this, the groups made like this will be definitely able to influence the society, the governments, and the future generations will have lesser caries or maybe reduced early childhood caries. The burden of early childhood caries in India has been increasing because of the change in the diet pattern, We eat more of westernized diets nowadays. The sugar consumption is increasing, and obviously the lack of awareness in many areas of the country. And even if there is awareness, there are a lot of myths, a lot of social stigma, a lot of inadequate knowledge that is further increasing the burden of early childhood caries. The estimated average prevalence of 40 to 60% is there, but a recent study by Akila Ganeshan and Dr. Muthu, it shows that the cumulative prevalence goes near 50%. So it's not a very small number, it's a very, very large number, and we should be seriously thinking about how to reduce it and how to improve the life, growth, and well-being of our children, because it is being ignored. The early childhood caries does not only affect the child, it affects the family. If you take one child to the hospital, what will happen to the other child? Either that child will be left to somebody else to take care for that day, or that child will also accompany this child along with the family to the hospital. So we do not only influence the child, we also influence the whole family. Then another thing is the early childhood caries in a child actually brings about a lot of stress within the family. We as clinicians see it day in and day out that as soon as we inform to the parents that your child has this many cavities which requires this many number of sittings, and we see that the parents start discussing between each other that why don't you brush, or why don't you take care, or why did not you come early to the hospital. So the parents, they also discuss within themselves, and sometimes it results in argument. We all know it. And why I'm specifying it here is that ECC is not only influencing one child in the family. ECC is actually influencing the whole family, their well-being, their mental health, their economy, everything. So we have to see it from a very, very different perspective rather than just talking about the disease. Now, uh, we know that it is preventable if we properly manage the common risk factors. We can reduce ECC to a large extent. And ECC prevention includes all the principles of prevention that starts from the prevention, maybe primary or secondary prevention or primordial prevention, disease management. It also includes there should be adequate access to dental care services, and it should be integrated and coordinated within the system. So my next few slides will cover on how our national program works, what are different components in which ECC prevention can be taken up, and if we do that, how much we can achieve. So in terms of prevention, what the government system can do is fluoride application, bacterial reduction by good oral hygiene, oral health education and anticipatory guidance are possible. In terms of disease management, we can do risk assessments, and we can manage the whole spectrum of dental treatment, beginning from very, very preventive like topical fluoride application to the maximum of whatever the restoration or the crown is. The access to dental care, if it is improved, and if we have adequate number of dental professionals to see the children at age 1, I'm sure we'll be able to reduce ECC to a very, very large extent. The concept of dental home may not be very, very familiar with India, but it is a time when we have to introduce it. And with the changing time, with the COVID, we have also learned that we can also have virtual or e-dental homes where the dental profession is available to the parents and the children electronically through the mobile or smartphones, and they will be able to provide them preventive advices and, if required, referral and treatment. The integration and coordination, I'll be covering it in future slides. So, in the health promotion, primary healthcare, and healthcare services, we have four major things to do with the National Health Mission and its various components. Then an offshoot of National Health Mission, which is Rashtriya Bal Swasthya Karyakram, popularly known as RBSK. And I'll be referring this word RBSK during my presentation today at many times. Then the third scheme is Integrated Child Development Scheme, or ICDS, which we know commonly as the Anganwadi scheme. And the fourth is the state healthcare system, or the state health system, wherein they also do prevention as well as the healthcare or the service provisions. The ECC prevention requires five targets or five ways of approaching at it. The first one can start from pregnant women, wherein we do prenatal oral health care. We can instruct them about prenatal oral health care. Then the second is mothers and primary care groups. Third is the healthcare professionals. They need to be sensitized. Our pediatrician colleagues, with all the people, those who take care of children, the people who do vaccination and all. Then fourth is the community approach, and fifth is the policy makers. They should be targeted. Now, how and where is being covered here. So first of all, I would like to talk about the National Health Mission. National Health Mission is a relatively new name given to integration of the two programs, which is National Rural Health Mission, which was launched in 2006, and then the National Urban Health Mission, which was launched in 2012. So initially, these two programs ran parallel to each other, but past 3-4 years, the government has merged both of them, and now it is called as National Health Mission. It is not a true vertical program in which the governments fund to the lower bodies and to the districts, and then coming to the panchayat level. It is little different. In this NHM scheme, the local governments at the panchayat level or a sub-district level, they decide their own priorities. The cell at a district level, they make a plan for their district. Then they send their district plan to the state government. The state government then decides the whole state's, compiles the whole state's needs as per their plan submitted, and then they present it to the central government, and then the central government approves that plan and gives the funding. So in the program is not vertical down, it is vertical up. Means as per the need, the plan is made, the funding comes from the top, means from the central government or from the top officials of the state government. So in this approach, what happens is that the actual community which needs the intervention, their need is assessed, and based on that, the projections are made. So this is a very good and very popular approach, and it is doing very well in our country. Being a very, very large economy and large size of population, this kind of thing was required. The main pragmatic components of the NHM are the health system strengthening, means the services improvement, the reproductive, maternal, neonatal, child and adolescent health development, then covering various communicable and non-communicable diseases. And the bottom line for the NHM is to have universal access of equitable, affordable and quality healthcare services, and the system which is accountable and responsive to the people's needs. And the NHM covers almost all programs under the health ministry, except one or two. So I have used some jargon of words here: equitable, affordable, and quality healthcare services. So for the people, those who have not understood, I repeat again, because the program, the implementation plan is made by the actual society at a panchayat level or a sub-district level. And then it is also implemented, only funding comes from the top, but it is implemented by the same people. Therefore, we say that it is equitable, affordable and quality, and accountable, because the same people, those who are making the plan, are also implementers. What used to happen in the past, maybe 20-30 years ago, is that the plan used to be made by people sitting in New Delhi, and they did not know what is the actual need of that community. So there were many programs in which that particular society did not have that burden, but the money was reaching for that. And for the actual problem which that community had, for that there was no program. For an example, in a particular community where fluorosis is high, but malaria is low, but the government has sent money for malaria not for fluorosis. Sometimes it can happen reverse. But in the case of NHM, what happens is the people sitting there, they would know that their universal problem is malaria. So they would make a plan for malaria control. They'll propose their budget, the manpower, the infrastructure, and then the central government will approve. Means it will go step by step, but the central government will approve, and then it comes back. And because they know that they have made this plan for malaria and they have to implement, so they become accountable and they become responsive to the people's need. And this system is little flexible also, that in a year twice you can change the plan. So suppose COVID came in between. So the people at the district or sub-district level, they could make the COVID related their plan. They could submit to the government and they could get it. So if there is a change in situation, it is also responsible. So this is the most strong part of National Health Mission and which should be utilized by us. Now, as a part of NHM, the National Oral Health Program or NOHP has been envisaged in 2012 or 13, and slowly and gradually it has progressed now to a larger level. We had a pilot project starting in year 1999, but after the pilot project was over, that time NRHM was in making, and in between for maybe 5 to 7 years, we did not have a lot of significant work in National Oral Health Program. But I can say that 2012 or 2013 onwards, we have been doing very well in terms of implementation of National Oral Health Program. Yes, for a larger country, it takes time to progress, but we are still doing very good. And I hope those who have heard Dr. Swastika speaking would definitely know that how much we have progressed in past 7 years of implementation. I'm reducing 1 year because of COVID. Now, the components of National Oral Health Program also has two things, which is central and state component. The central component mainly covers the development of training modules, IEC materials, that is information, education and communication materials development. Then the central government is also doing establishment and support of oral health care units or the dental clinics for the state governments wherever they do not have. It is a stepwise approach in which if the state has at district level dental surgeons, then they can apply for enhancing it to sub-district level. If they already have up to sub-district level, they can apply for community health center. Like that, they can do stepwise escalation. And you must have heard Dr. Swastika speaking already that now we have more than 4,500 such units supported by the central government and the state. And this is not only establishing, this is also supporting them every year for the consumable and for the repair, if any, for the dental chairs and equipment. Then the central component also look after integration with other programs like National Tobacco Control Program, the National Program for the Healthcare of Elderly, other non-communicable diseases program, and of course with the Rashtriya Bal Swasthya Karyakram or RBSK. I'll be coming to that a little later. Then the central component also has National Center of Excellence, which is declared in AIMS in 2014. We are supporting the central government in various aspects of the implementation of the program. We are a technical support to the central government. Then last 2 to 3 years, the central government has also started working on development of various resource centers. And as of now, 3 of them have been declared on tobacco cessation by dental professionals, the oral free malignant conditions, and then one center in PGI Chandigarh for the geriatric and pediatric oral health. Then the central component also envisages to help research support and the monitoring of the program. The state component is basically it's a customized planning and implementation. They also do training, awareness, and of course service provision by the state government as such is already there, as well as many of the dental care services supported by the central government. Now, for integration of oral health under the umbrella of NHM, we have 3 major things to talk about. ICDS scheme, which I already talked, 1975 it was started. The form has been changing constantly with period of time as we learn lessons. We have been changing the implementation plan for ICDS, but largely it is taking care of the children, preschool children. RBSK is a very strong program, and it's still in the stage of development. It has not been implemented fully functional in all the states. And then the third is Pushan Abhiyan, which is actually a renaming of the midday meal program with certain modifications in that by this government. So the ICDS program is an ideal example of community participation under the primary healthcare concept, and it is considered to be the largest community-based outreach program, and it has got several packages for 0 to 6 years children, pregnant and nursing mothers. And these services are offered through the Anganwadi centers, through the Anganwadi workers and Anganwadi helpers at a grassroots level. It covers 6 services: supplementary nutrition, preschool and non-formal education, nutrition and health related education, immunization, health checkup, and obviously the referral services. So in every aspect of it, the dental care, oral health care for the preschool children can be covered. It enhanced from it has been enhanced from only survival to healthy survival of the children, and ICDS has been largely effective in the areas where the deprived population was there. And Anganwadi is normally covering 1,000 population in the urban and rural areas and 700 in the tribal areas. So in each little area, they are allocated with some space in which that is called as Anganwadi, in which they can have education for the children, they can gather the mothers for their education, they can plan vaccinations, they can plan camps, like that it works. So that is a place where a lot of things can happen. So Anganwadi is normally there is a monthly meeting of all the mothers of that area, wherein they talk about a lot of education, so they can talk about oral health. Basic oral health awareness can be done to mothers through these centers. Counseling can be done about, and the oral health care delivery can also be planned in certain areas where the state governments are doing camping with the help of those Anganwadi workers. And Anganwadi workers also provide outreach services by going home to home with the help of the healthcare system, and that can work very well for ECC prevention. Then, if we give adequate knowledge to the Anganwadi workers about the not only the direct risk factors but the indirect factors of dental caries, it will be very, very helpful, because this information will definitely reach to the population at the grassroots level. Anganwadi workers screening by themselves, if they are trained to identify dental caries, then they would be a very good help in early detection and early referrals. And they are a very, very promising workforce, because it's a well set program. Now almost implementation is 45 years, so we know that this works. Then the next is a very, very ambitious screening program for 0 to 18 years of age, called as RBSK. Again, the concept is from survival to healthy survival, health survival for the children. It aids in screening and early intervention services for the children up to uh, age of 18 years, and it covers 4 Ds: defects at birth, deficiency diseases, other and non-communicable diseases, developmental delays, including disabilities. So in this, two of the dental care things come. One is the dental caries, and the second is dentofacial defects and cleft lip and palate. So if they are screened at an early age, they can be referred appropriately and they can be treated. In the RBSK system, the original envisaged plan was to develop district early intervention center, wherein all the experts will be there for the children and they will be treating them. As of now, DEICs are functional in many states, many districts, but not fully functional in terms of dental care. So if we make a little change in RBSK in identifying the early changes for dental caries and white spot lesions, we will be able to serve our children in a better way. The healthcare delivery can also be taken up because we will have the data of the children, we'll be able to do preventive part or early restorative part uh, for the children screened under RBSK. The dental units which are supported by the National Oral Health Program, which supports manpower, equipment, and consumables at various levels in the states, they can also support and augment the efforts of RBSK, because RBSK teams can refer those children after screening to these facilities for oral health care. Then the third is the Poshan Abhiyan. It envisages to give balanced diet to all children, irrespective of their schools. It is comprised of all essential components spread from the over the week diet, and it is very, very successful going in many states. How dental health can be for the children can be integrated is rinsing before meal, brushing after meal, periodic checkup during this meal distribution, and fluoride mouthwash if possible in certain states. We know that some of the areas in the country have been trying to implement fluoride mouthwash during midday meal. So this is still in progress, and I hope that it will work out well. But when we talk of all the positivity, we also have a lot of things to think about the barriers. There can be patient level barriers and community level barriers. They've been covered in the previous presentations, but it is important for us, for me to remind that yes, talking all positive and integration, talking that does not help. We should also know the barriers and we should try to remove those barriers. We do not have good accessibility, affordability of the dental treatment. People do not acknowledge, even after knowing, they do not acknowledge the importance of oral health. Then the community level problems are the budget allocation is low, especially by the state governments. Central government has enhanced its funding for the past 7, 8 years now. They have been allocating whatever money required for dental health. Actually, in the NHM system, this is the best thing is that under the mm, allocation for infrastructure, dental health is not counted separately. So when you try to see the government's website for the budget allocation, probably the budget allocation which will be visible there will only be for the central component. That is a very small amount. But what goes under the state component is allocated by the NHM secretariat. And there they do not have a separate heading by the name of oral health. So we would not know, but actually it's a huge, huge amount of money which is being spent on oral health care for the country. And it's enhancing every year by year. That's what is the example that 4,500 facility being funded by the central government. Now, when we talk of the integration model for different age groups, then yes, we know that Anganwadi workers work very well for 0 to 2, 2 to 3, and 3 to 6 years. But RBSK has now come into play. So there it can be done for these age groups, and 6 to 16 years is midday meal or Poshan Abhiyan would work very well. So these are the details that at 0 to 2 years, Anganwadi workers and ASHA workers of NHM can work very well in tandem with each other. They can do education, they can do the early detection. And these workers also have the access to health records of all the children. So that becomes valuable that in an area, if they know where the problem is, there a government facility can reach. If the child cannot reach to the hospital, the mobile dental van can reach. 2 to 3 years are in the best position to benefit from fluoride varnish applications, and that can be tried using Anganwadi and RBSK both, and can be also done using mobile dental van supplied as a part of National Oral Health Program (NOHP). And for certain areas in the country, we are also seeing the Indian Dental Association or some of the non-governmental organizations are also supporting the government in such efforts for the preschool children. Then midday meal scheme or the Poshan Abhiyan is helping a lot in improving the health of the children up to 16 to 18 years of age. There we can also incorporate the components of hand washing, toothbrushing, rinsing and all. And the training of school teachers can be done as a part of these programs to assist the children and educate the parents. Here, I would also like to mention that we can also add prevention of dental trauma, although not relevant to ECC. But yes, it is important for the children. So my take-home message is that ECC prevention should be a national priority for dental profession and policymakers because it is a social inequality. It is a matter of injustice to those children who are not able to take care of themselves. So it should be our priority, national priority. Then the message for the people, those who are listening today, I assume that most of you are dental professionals, and it is important for us to not only do the epidemiological surveys to find out the prevalence of the disease, but we should cover the data which I spoke earlier on the influence on quality of life, influence on the economy, influence on the family, influence on the mental health of the overall family and society. If we have those data, we'll definitely be able to influence the policy and funding. And last but not the least, I want to say that whatever I have said today is achievable within the existing system. It is only the requirement is that we as dental professionals should come out of our offices, our clinics, our hospitals, our workplaces, go to our policymakers, meet them, influence them. If we do that, certainly we are going to prevent early childhood caries. Thank you very much for all your listening and patient listening, actually. It was a lot of dry policy related content, but I hope you enjoyed it. Thank you very much.